Hello, my name is Mark Edwards. I'm a professor of neurology at St George's, University of London. It's a great pleasure to be with you today at this event organised by Dystonia Europe, and I'm very honoured by the invitation to talk to you today. Of course, it would be nice to talk to you in person, but with these times, we're used to doing things electronically. But I hope you enjoy this presentation. I'm looking forward to the live question and answer session a little bit later on today. So I'm going to start by talking about a big question, I suppose. What is dystonia? And to think about that in terms of the different types of dystonia and also how one goes about a diagnosis. So dystonia is a problem with the way the brain is controlling the muscles. So it's a movement disorder. It's a problem with movement control. And the thing that's gone wrong is the control of movement in the brain. And so that means that the messages that are being sent from the brain to the muscles are incorrect. And that means that in people who have dystonia, the muscles are doing things that the person doesn't intend, they don't want to do. It's an involuntary movement disorder. And the problem is of sort of abnormal control of the muscles. So the muscles are tense, they pull, they're contracting when the person doesn't want them to. And this produces posturing of the body. So it pulls the body into abnormal postures. And often at the same time, people get tremulous movements, or shaking, and even jerky movement as well. And because there's a lot of muscle tension and pulling, and because the posture is abnormal, it often causes pain and discomfort alongside the abnormal muscle activity. So dystonia is just one word, but there are many different experiences that people have with dystonia. And that's because dystonia is actually the result of lots of different neurological problems. So that means that one person with dystonia, their experience might be very different from another person with dystonia. And that's because the actual problem that's happening in the brain that's causing the dystonia is different. But actually, even in people who've got the same cause of dystonia, sometimes the symptoms and the level of disability can be quite different one person from another. So it is one condition in a sense, that this is a condition where the brain's not controlling the muscles in a particular way, causing abnormal postures. But there's lots of different causes and lots of different personal experiences of what happens with dystonia. And I think that's important to recognize, particularly when you're in a meeting such as this with lots of people who likely have lots of different types of dystonia. Obviously, not everybody's experience is going to be similar to your own. So I was going to talk through some common symptoms that people who have dystonia would tell me about in clinic. So the first is of pulling and tensing of muscles. So that means that when the muscles pull, particularly around a joint, for example, in the hand, you might pull up one side and not the other side, that you get abnormal posturing. And that can affect just a single area of the body. So that's sometimes called focal dystonia. A number of areas which are sometimes next to each other. So down one side of the body might be hemidystonia, maybe the neck and arm would be segmental dystonia, or maybe the whole body is affected, as in generalized dystonia. And alongside this, there's tremor and shaking quite frequently. That can sometimes be of the bit of the body that's affected by dystonia. It can sometimes be of another part of the body. So somebody might have neck dystonia that pulls the neck, but also their arm might be shaky. And the tremor is often quite jerky and jumpy, and sometimes it's only there in particular positions. So for example, maybe when the person's hand is close to their mouth, it might be shaky, but when it's far away, it's less shaky. And there are some people where tremor is actually the main problem, and the posturing and pulling bit of dystonia is not such a big problem. As I mentioned before, pain and discomfort caused by the muscle pulling itself and also trying to compensate for the pulling, that's also usually quite a big problem, particularly for people with neck dystonia. It's not usually the overwhelming problem, but it's certainly often a big part of the problem for people with dystonia. Now, there are lots of other symptoms that people experience, some of which, a bit like pain, don't really have anything to do with problems with movement. So, for example, people can get fatigue as a problem. People can sometimes feel low in mood or anxious. And so there's a wide spectrum of problems that happen to people with dystonia around this core problem with abnormal posture. So there's some things which people with dystonia experience which seem on the surface to be a little bit unusual or strange, but actually they're very common features of dystonia. So first of all, dystonia is often made worse by movement. So dystonia is often action-induced. And that might mean that somebody may be sitting still and they don't have too much dystonia, but when they go and move, the dystonia gets much worse. And another side to that is something called overflow, which means that, say, for example, somebody has dystonia of their arm and they move their arm, but when they do that, they might get overflow, for example, to the neck. And that can even be seen on the other side of the body. So again, particularly with people with hand or arm dystonia, when they move their limb affected by dystonia, the other one may move a little bit as well. That's called mirror movements. Some people with dystonia only get the problem when they're doing a very specific task. So, for example, playing a musical instrument or writing or typing. So dystonia often shows this task specificity. And another common feature of dystonia is that it may be relieved a bit temporarily by touching the affected part of the body. And this is called a sensory trick. So, for example, people with neck dystonia often may lightly touch their face, and this might help bring the head into a more normal position. So these are all common features of dystonia. These are things that neurologists who have an interest in dystonia would be asking about and looking for. But it's good to know that I think that they are common symptoms, because on the face of it, they can seem a little bit unusual. So if we're going to think about now types of dystonia, sometimes doctors will talk about dystonia or describe dystonia based on where it affects you in your body, and also maybe how old you were when it started. So you might talk about generalized dystonia, where it affects the whole body, or hemidystonia, where it's down one side, or focal dystonia, where, for example, it just affects the hand or the neck. And there's other words that are used to describe bits of the body affected. So blepharospasm means dystonia affecting the muscles around the eyes. Oromandibular dystonia means dystonia affecting the jaw. Cervical dystonia, the neck. Craniocervical, so the neck and face. Axial, meaning the back, and limb and hand dystonia. And then doctors might talk about infantile onset, where dystonia comes on as a baby, or childhood onset, or adult onset. So these are all descriptive terms that are used to talk about dystonia from one doctor to another, and doctors might talk to you about the fact that you have generalized dystonia, or you have blepharospasm, or you have adult onset dystonia. I think it's important to realize that these are just descriptions. They don't really talk about the cause so much. I'm going to come on to that in a second, but they're ways of describing medically what is happening. The more useful way, I think, to talk about dystonia is to try and think more about the cause. So what is it that has actually gone wrong with the brain to cause the dystonia? Now, sometimes it's actually very difficult to know what that cause is, particularly when you first meet somebody. But there are terms that you can use in some situations. For example, isolated, secondary, degenerative, paroxysmal, functional dystonia. So these are all different types of dystonia. And I'm going to go through each one of these in turn. So starting off talking about isolated dystonia. So this is probably the commonest, or certainly a very common form of dystonia. And typically what people experience is that the symptoms come on, so people develop dystonia, they maybe get a bit worse over a period of 6 months to 12 months, and then they usually stay fairly stable. And other parts of the nervous system, such as sort of memory or things like that, are not affected. So it's just dystonia with tremor, but not a sort of progressive problem. It's not that brain cells are gradually stopping working. It's not that people develop lots and lots of other symptoms in other systems, other parts of the nervous system. It's an isolated dystonia. Now, there's probably at some level a genetic basis to lots of people who have isolated dystonia, but actually we only know a very few genes And genes for dystonia do seem to be ones where they're not necessarily passed on very strongly from one generation to another, or at least people don't develop symptoms very strongly from one generation to another. So there's a way in which dystonia shows itself, isolated dystonia shows itself depending on how old you are when it develops. So typically, if you're a child and you develop isolated dystonia, it would often affect the whole body. If you're a young adult, it might be affecting your hand, for example, a task-specific dystonia. And if you're an older adult, say in your 40s, 50s, 60s and beyond, you would tend to get focal dystonia that might affect the head and neck. So there's a sort of difference in the way isolated dystonia shows itself depending on how old you are when it develops. So just starting with children, wanted to mention about this condition called DYT1 dystonia, and that's the commonest cause of isolated dystonia in children, and it's caused by a change in a gene called the DYT1 gene. It is quite a lot commoner in people who have Ashkenazi Jewish heritage, but actually it can be present in all ethnic groups worldwide. It causes onset of dystonia, usually in childhood, and then it usually gets worse for a period of time, becomes generalized, and then stabilizes. Actually, only about 30% of people who carry this gene problem get dystonia. And it's one of the types of dystonia that typically responds extremely well to deep brain stimulation surgery. There are a couple of other childhood dystonia types I just wanted to mention, particularly dopa-responsive dystonia. Now, this is a rare condition, but it's an important one, because if you make a diagnosis correctly, then giving dopamine makes the symptoms usually completely or almost completely better. So it typically presents in children with slowness and stiffness in the legs and dystonia as well, usually as a pattern of the symptoms worsening as the day goes on. And then when people have been to sleep, it's a bit better in the morning. And it's due to a genetic problem with dopamine production in the brain. As I say, if you identify this, and if it's that condition, you give people dopamine, it makes symptoms dramatically better. So it's a very important condition to recognize. There's another condition I just wanted to mention which presents in children called myoclonus dystonia. And that's where people get electric shock-like jerks of the body, which is myoclonus, and also dystonia affecting the neck. So there are some dystonia conditions which are, in a sense, isolated dystonia conditions, although dopa-responsive dystonia, myoclonus dystonia, classified a little bit differently. It doesn't matter too much. These are all conditions which are not progressive, but they present in childhood with dystonia. So I then wanted to talk about sort of isolated dystonia usually in younger adults, and that typically causes a hand dystonia, and it's typically something that affects a skilled task. So there's one common form that affects about 1% actually of professional musicians, something called musician's dystonia. And in that condition, somebody who's a professional musician, so they're practicing extremely hard, usually many, many hours a day, will develop often a very subtle problem with movement control in the hand. It can sometimes actually affect the mouth in people who are wind or brass players, something called embouchure dystonia. And typically the problem is only present when playing the instrument, and when, for example, the hand is being used for another task, things are normal. So it's often only quite a subtle problem that happens, but obviously for a professional musician, that can be a really devastating problem in terms of being able to perform. And there are people who do other tasks, such as writing, typing, and so on, so other skilled tasks can be affected by this condition. So it's one of those types of dystonia where, at least in theory, rehabilitation or retraining may offer help for some people, although it can sometimes be quite hard to get access to that sort of treatment, depending on where you live. But it's an important type of dystonia to be aware of. Sometimes people just have typical dystonia affecting their hand, and obviously it's going to affect tasks like writing, but it affects everything else as well. And then it's going to move on to isolated dystonia that's affecting sort of older people, so people in their, usually from their 40s and plus. So this is craniocervical dystonia. So these are types of dystonia that affect the muscles of the face and neck. So cervical dystonia or torticollis oromandibular dystonia, which affects the mouth, laryngeal dystonia affecting the vocal cord, something called Meige syndrome, which affects the mouth and eyes, and blepharospasm, which affects the eyes. All of these conditions are commoner in women than men, but they occur in men as well. Neck dystonia, as I mentioned before, is often quite painful. And these are the kinds of dystonia that are often treated with botulinum toxin injections. So these are focal dystonia conditions, but they're isolated. So here's some pictures here of different positions that cervical dystonia can cause. So torticollis, meaning a rotation of the neck, laterocollis to the side, anterocollis forward, retrocollis backwards. And some people have combinations of these patterns. So by recognizing the pattern and recognizing the muscles that are overactive and causing the pulling, they're the muscles that you would tend to target with botulinum toxin injections to reduce their excitability, to calm them down, and to allow more normal movement to happen. So that's a quick run through isolated dystonia, which is dystonia alone, with or without tremor. It's something that is not typically a progressive problem, and it causes just dystonia, but obviously it can be these can be very disabling conditions, even though they only cause dystonia itself and not other problems. And they seem to have a different way they affect people depending on when they come on, with generalized dystonia in childhood, these task-specific problems in young adults, and then these craniocervical type dystonias in people who are a bit older. So that's isolated dystonia. So now it's going to talk about secondary dystonia. So that's a situation where dystonia has been caused by another illness or another sort of triggering event. So a common cause of that would be damage to the brain. So for example, there are some people who have damage around the time of birth, typically from loss of oxygen to the brain during delivery. And so that's a situation which can result in dystonia and often other problems too. Sometimes when people have a stroke in a particular part of the brain, they can develop dystonia. Sometimes if people have a traumatic brain injury, for example, they have brain injury that's occurred in a car accident, then that sometimes can cause dystonia. So dystonia is a problem with the way the brain's working. If you damage the brain in a particular ways, sometimes that can result in dystonia. There's another type of dystonia which occurs in response to a particular medication, and this is medication that blocks dopamine receptors. So dopamine is an important chemical in the brain, important chemical in movement, and there are certain medicines that block the receptors that this chemical binds to. And those medications are typically used in the treatment of severe psychiatric problems such as schizophrenia, although sometimes they can be used in other situations, for example, as treatments for nausea or dizziness. And in a small proportion of people who are exposed in the long term to those medicines, so typically months or more usually years of exposure, sometimes people develop dystonia. And unfortunately, often, even when one stops those medications, the dystonia stays there. So that's something called tardive dystonia. Tardive meaning it's happened after a long delay. So these are events, if you like, medical events or illnesses or exposures to drugs which can trigger the development of dystonia. So when people develop these sort of secondary dystonia conditions, they're usually static. So they develop, but they don't tend to progress because it's as a result of a particular injury, for example. And if that injury stays the same, like it does in a stroke, then people remain with the dystonia. There's another type of dystonia, which is called degenerative dystonia. And so that's when dystonia is happening as part of a much wider disease process in the brain. So that means that there's a neurological disease process going on, which is causing brain cells to gradually stop working, widespread in the brain. And dystonia happens as part of that process, but typically people have lots and lots of other problems as well. And because this is a degenerative problem, so it's keeping going, this loss of brain cells keeps going, tends to get worse over time, and people develop other neurological problems too, alongside the dystonia. Now, there's lots and lots and lots of different causes of this, and this is a situation where there would often be quite a significant amount of investigation to try and understand what the cause might be. Unfortunately, that typically doesn't lead to actually being able, at the moment, being able to do something to change the course of that illness, but it can be important to try and understand what it is that's causing it. So these are degenerative type of dystonia. So we talked so far about isolated dystonia, about secondary dystonia, about degenerative dystonia. I'm just going to talk about a couple more types of dystonia, paroxysmal dystonia and functional dystonia. So in paroxysmal dystonia, what happens is that dystonia happens in attacks. And in between the attacks, people typically have no symptoms at all, or certainly much milder symptoms. So these are usually genetic problems. They usually present in childhood or teenage years. And in some types of paroxysmal dystonia, there's particular triggers to the attack. So there's a type of paroxysmal dystonia that's triggered by sudden movement, for example, or a type which is triggered by prolonged exercise. And making a correct diagnosis for these types of dystonia is important because there are some specific treatments for these rare types of paroxysmal dystonia. So there are rather unusual conditions. It can be difficult to make a diagnosis, sometimes difficult for them to be recognized correctly. But they are important conditions because they certainly cause symptoms, but there can be specific treatment that you can give. And lastly, I wanted to talk about functional dystonia, which in previous years would have been called psychogenic dystonia. So functional dystonia is part of a wider condition called functional neurological disorder, or FND. So functional dystonia is a common and genuine type of dystonia. It's just as real, just as disabling as other forms of dystonia. The thing that's gone wrong in the brain is a bit different. So instead of being a sort of wiring problem, it's a problem with being able to access or control movement, even though the person is trying as hard as they can, and even though the basic wiring of the nervous system is actually okay. So it's more of a malfunction of the way things are working. It can present in different ways, and the diagnosis is quite a difficult one, to be honest, and it needs really specialist sort of attention into understanding whether this is functional dystonia or not. But one common form, which is sometimes called fixed dystonia, usually occurs after an injury. And so often people would have an injury, for example, say to their foot or their hand. The injury might be a bad injury causing pain, but typically something which you would expect just to get better. But instead of getting better, people remain with severe pain, usually, and often a fixed abnormal posture. So fixed dystonia, so it's not moving around, it's just stuck in place. Now, as I said, making the correct diagnosis is important, can be a bit difficult sometimes, but it is important because there are particular types of treatment which can be more useful for people with functional dystonia, particularly multidisciplinary rehabilitation. So that's working with a group of professionals like neurophysiotherapists, clinical psychologists, occupational therapists, sometimes neuropsychiatrists, neurologists. So working all together to try and improve symptoms. So what we've talked about so far is the sort of what dystonia is as an entity. So there's kind of symptoms that it produces, posturing, tremors and jerks and pain. And then talk about the different types of dystonia, thinking about describing it just in which bit of the body is it affecting and what age it comes on, but more usefully in these different categories of isolated dystonia, of secondary dystonia, of degenerative dystonia, paroxysmal dystonia, and functional dystonia. So just to finish off, I wanted to talk now about diagnosis, and particularly diagnosis from a sort of practical point of view. So lots of people with dystonia tell me about the difficulties they've had in actually getting a diagnosis in the first place, and it's taken a long time for the diagnosis to be made. And there can be some problems right at the start. So the first problem, which is a pretty major one, is that actually maybe it's difficult to see a neurologist in the first place. And that's often because the problem is not really recognized as either dystonia or even as a neurological problem. So it might be thought of as a rheumatological problem or a pain problem, because that's the main thing. People might be a bit distracted by anxiety or low mood and feel that that's the main problem that needs to be addressed. So that can be a delay in getting a right diagnosis. But even though all neurologists should be able to recognize dystonia and to say, well, you have dystonia, getting a more detailed diagnosis and treatment advice really needs you to see a neurologist with the right kind of expertise. So there is a specialty within neurology called movement disorders, and movement disorder specialists would see people with dystonia alongside people with other kinds of movement problems, for example, Parkinson's disease or Tourette syndrome. So seeing a movement disorder neurologist should be the best way of not only just getting a diagnosis of dystonia, but really understanding exactly what it is causing it and getting the right kind of treatment advice. So what a doctor might do, what a movement disorder neurologist might do to make a diagnosis is very different one person from another. So for example, if I saw a lady in her 50s who told me about getting discomfort in her neck and then a gradual pulling of the neck to the side, which had happened over about 6 months, and it's sort of now fairly stable, maybe a little bit of tremor, no other symptoms at all, completely normal neurological examination apart from that, I would probably be happy to say that she is likely to have isolated cervical dystonia. I would do an MRI scan of the brain, but I probably, and I may do a couple of blood tests, but I probably wouldn't do any other investigations. Obviously, if that person then developed new symptoms and had other problems that I wouldn't expect for isolated cervical dystonia, I would investigate further. But then if somebody, maybe a lady in her 50s came, but she had dystonia which was affecting the whole of the body, that was progressing, developing other problems, for example, with memory or with spasticity, then that's the situation where there could be lots of causes of that. Sounds like a degenerative dystonia. And then I would be doing lots and lots of investigations. So it is a very personal thing. There's not a one-size-fits-all approach to making a diagnosis of dystonia. It really depends on the symptoms and the problems that are there. It is important to recognize that for people who have degenerative dystonia, despite very intensive investigation, sometimes it's just not possible to find a cause. And I think that can be a tricky thing because obviously people want to know what the cause is. But at the same time, just having endless rounds of investigations with no benefit is also quite a difficult thing to go through. And so it's important to understand from the neurologist who's seeing you whether the investigations are looking for things that are actually treatable, that would actually make a difference to treatment, or if they're really just trying to search for a cause which we might not find. These are difficult and, again, personal decisions, but it's important to have that, be able to have that dialogue or discussion with your neurologist. And that brings me on to my second to last slide, which is really thinking about how you can help your neurologist to help you, because neurologists generally would like to help people, but there are things that you may be able to do that can help your neurologist help you and for you to get more out of your appointment and more out of your care. So I think it's really important to tell your neurologist about all of the symptoms you have. So I've met many people who really just tell me about the symptoms they feel are neurological and that therefore as a neurologist I'd be interested in, but then don't tell me about lots of other things. So that's a shame because those other things are really important for me to know about because I'm interested in knowing about the whole of you. Those things might be relevant for the diagnosis, but also they might be relevant for me trying to help you. So for example, many people don't tell their neurologist that they feel depressed or anxious, but I would like to know that because that's about you, that's about the problems you're having, and I may be able to help with that. People might not talk about their pain, for example, even though that's an important problem that they're having day to day. So it can be good to write down all of your symptoms, and so then you have them in front of you and tell your neurologist about all of the things that all of the problems that you're having. And I think it can be good to tell your neurologist about how the symptoms are affecting you and your daily life. So if somebody says to me, oh, my neck is pulling, that's fine. It's useful information. But if they say my neck is pulling, and that means that it's basically impossible for me to do my job because I'm meant to be talking to customers and my head is pulling this way and I can't look at them properly, or something like that. So giving some context to your symptoms, and that can help you and your neurologist prioritize which symptoms are the ones that are causing you the most trouble in day-to-day life. So, for example, sometimes the pulling of the neck, for example, may not be the biggest thing. Maybe the pain is the biggest thing, or maybe tremor is the biggest thing, or maybe low mood is the biggest thing. So understanding the symptoms in the context of your own life is very important for your neurologist to know. And it's also really important for you to be honest with your neurologist about whether the treatment's helping or not. So as a neurologist, I'm not going to be offended if a person with dystonia says to me, actually, the botulinum toxin injection you gave didn't really help me, or that medicine you gave me really gave me bad side effects. I would like to know about that. So be honest about the effects and side effects. And it can sometimes be useful to keep a record and write it down so you remember whether something's been useful or not. I've heard from many people that they have lots of questions and concerns before their appointment, but then they get into the appointment and they forget to ask half of them. And that's a normal thing. It happens to me if I go to the doctor as well. And so it's useful to write down the questions you have and concerns you have. And that makes sure that they're covered in your appointment. You should have a chance to ask them. And I think it is also very important that this is your time too. So if you don't feel that your concerns have been heard, then make sure you explain that to your doctor. Now, doctors are human beings too, and they might just not realize that they haven't paid enough attention to something that was important to you. So it's important for you to say that, to voice your concerns. Obviously, there can be hopefully rare situations where you just don't have that relationship. You don't have a relationship where you can talk to your doctor and explain what's wrong and feel that they've understood. And that's a tricky situation, but one where if you can, it might be useful to try and seek another opinion. But I think in most situations, neurologists are wanting to help, but sometimes you need to tell them in what way they could best help you and what things concern you the most. So just with the last slide, I was thinking about that a bit more. And it's not just about helping your neurologist to help you, but it's also helping you to help you too. And that's a bit where I think knowledge is power to some extent. I mean, there are other aspects to this, but sort of knowledge is perhaps a really important thing at the foundation of trying to manage with an illness. So being ill with dystonia, it can be a frightening experience. It changes the way that you feel about yourself. So understanding what's wrong and what to expect in the future, that's a really important step to try and sort of take back control in a way. And I think that's, part of a session like today is important. Organizations like Dystonia Europe can be important like that. Talking to people who have dystonia can be important. So there are lots of ways to try and get this information. It can be tricky, like I said at the beginning, that there are so many different causes of dystonia that one person's experience may not be completely applicable to you. So that's a tricky aspect of all of this. But really trying to understand your condition in your context is important. And then I think what comes from that is trying to find ways to still be you, be the person that you are with your values, with your aspirations, with the things that you want to happen in your life, even though the dystonia may make it difficult to do that in exactly the same way as you used to, or exactly the same way as you expected you would be able to do at this point in time. Now, that's, of course, an extremely easy thing for me to say, and it's an extremely difficult thing to do. But I think that trying to find a way, if it is possible, to continue to be you, even if you're doing it in a way which is actually quite different than what you expected you would be doing. And the reason I think that's so important is it's a way of trying to get more in control rather than just simply being controlled by dystonia or being controlled by doctors or other people who are involved in your care, etc. And it's a way of you being more in the center of all of this and having things that you can do which are really trying to push the condition as far as possible into the background to allow you to continue to do the things that you want to do. Now, I appreciate that that is a very hard thing to do, and is also different for people with different types of dystonia. But I think it's important general advice in terms of trying to manage with a long-term condition such as dystonia. So I hope you found that useful, talking about the different symptoms that dystonia can cause, the different types of dystonia, the ways in which you might approach diagnosis as a neurologist, and also thinking how to maybe take a bit more control of the interactions you have with your neurologist, and also the way you're managing your symptoms generally. So thank you very much for that, and I look forward to the live discussion later on.